Well, it's 7 o'clock, and the good thing about Zoom is that you always do get to start on time and finish on time. So thank you. As people are joining, I will just say hello and give a brief introduction, Jamie, and let you take it away in just a minute. Thank you all for joining us this evening. I see lots of people popping on right now, so maybe pause a minute. Really happy that we can offer you Jamie's wisdom tonight, even despite the threat of scary weather moving our way. I am Dr. Molly Braid. I'm the chair of the Department of Nutritional Sciences, and it is my great pleasure to welcome you to the 2023 Jean Andrews Distinguished Lecture. Every year, it's a little different, and this is the first time we've done it on Zoom when the visitor is actually here in town. But we're glad you're here, Jamie. Tonight's speaker, Dr. Jamie Ard, is a nationally and internationally recognized expert in obesity treatment and research. Among his many accolades, he is the president-elect of the Obesity Society, which is one of the largest professional societies for obesity researchers and clinicians. Obesity is one of the thorniest public health issues that we face, and it affects a whole host of comorbidities, as you'll hear about tonight, I'm sure. It affects millions of adults and children worldwide. Dr. Ard's special expertise is actually in treating some of the most challenging patients with obesity, those from underserved populations and those with severe obesity. He can tell you wonderful stories about success in the clinic where people have lost weight and maintained that weight loss. And he can also tell you many heartbreaking stories of people who have struggled with their weight lifelong and continue to struggle. Dr. Ard is a wonderful colleague. He is a passionate and compassionate champion of health equity for all. And I'm super happy to present Dr. Ard to you this evening. So clapping myself, Jamie, and I'm sure everyone else is clapping too. Take it away.
All right. Well, thank you again, Molly, and thanks to the audience for being super flexible and joining us virtually. I guess 4 years ago, 5 years ago, maybe we wouldn't have been able to do this as easily as we are today. But I am super honored to be named as the Jean Andrews Lecturer for this year, and it's been a real wonderful visit here to UT Austin, and I am thrilled that at least I get a chance to share with you at least some of my thoughts this evening, despite the weather concerns on obesity and health equity. And I hope that I can challenge you to be a part of the conversation and really sort of lend your brain power, your talents, your thoughts to the work that we're trying to do more globally. So let me go ahead and get to it. And I want to make sure we've got plenty of time to cover everything here. So what I want to do is spend a little bit of time sort of orienting you to how we think about obesity, because I think having that level set on obesity as a disease is really important to making sure that we're all starting from the same place. And then I want to pivot into talking about health equity as it relates to obesity, because I do think that really understanding health equity will change how we think about obesity and the provision of treatment for obesity, both active treatment as well as prevention and prevention level interventions. I think that will help us change the conversation globally when we can start to have conversations in this construct of health equity. And so I am going to try to convince you that this is an important way to think about this, and that there are real challenges within this space when we think about the health equity issue as a frame for obesity. So let me get started here. And I'm gonna want you to start by imagining if there were a disease that affected, let's say 4 out of 10 adults in the US, and imagine that that disease also affected about 20% or more of children. And let's say that disease has significant impacts on physical function. It led to lots of disability, physical disability. And let's say that disease also was contributing to increased mortality trends across all racial ethnic groups, but certainly people of color were seeing, high rates of mortality related to this particular disease. And by the way, this disease is causing lots of other chronic diseases like diabetes or hypertension, cancer, heart disease, Alzheimer's. It's contributing to stroke. It's contributing to cognitive decline. Let's imagine that that disease is doing all of these things. It's affecting a large proportion of people. It's killing people. It's creating other diseases. It's causing decreases in quality of life. But this disease is only being treated in 2 to 3% of the people who should actually get treatment. Now, that's hard when you think about that. All those problems, but only 2 to 3% of people are getting the type of treatment they should actually get. We have to step back and wonder, like, what's going on? Why is that the case when we have a disease that is so bad? And why wouldn't we be more actively treating, more actively engaging people who are suffering clearly from this problem? Well, this is what obesity is. This is the challenge that we have in the space of obesity. Obesity is a chronic disease that is costly, it is complicated, and it's very much undertreated. And so when you start to put all these challenges together, it really becomes mind-boggling to think, well, why are we in this position that we're in when we see the rates of obesity increasing, but we're doing very little to actually treat patients who develop this chronic disease, even though it's costing us a lot of money and it's complicating people's lives. And it's, really leading to lots of other disabilities and complications. So how do we really think about obesity as a disease? Because for some people, that may be a new concept or a different way of thinking about it. And so I'm going to spend a little bit of time in these next few slides trying to give you a basic sort of overview of obesity as a disease. There could be a whole talk on just this topic, but I want to at least give it a few minutes here to level set. So obesity is a chronic relapsing disease. Relapsing meaning if you stop treatment, the disease will relapse. It will return back. It will return to where you were previously. And that's true for any chronic disease. You stop treating diabetes, that blood sugar can be well controlled and it will go up again. Or the blood pressure, you stop taking blood pressure medicine, you might have well controlled blood pressure will increase again. So there's not a cure for obesity, okay? It results in excess fat mass, all right? Obesity is something that results in excess fat mass, but the primary abnormality is an abnormality of regulating how your body balances energy intake and energy expenditure, okay? That is the primary dysfunction. It's not the excess fat. The excess fat is a complication of or a consequence of the abnormal regulation of energy. Another way to think about it is obesity results in a state where excess weight gain is easy and weight loss and maintenance of that weight loss is difficult. And any one of us who tried to lose weight and found ourselves regaining that weight will attest to that. And so what's the central problem? The central problem, as I said before, is about the dysfunctional regulation of energy. Energy imbalance is the result of that. And then you accumulate additional fat. That fat can be deposited in various places under the skin, for example, around the organs. Around the organs is not where you want it. Or in the organs, like in the liver, that's not where you want it. When you put that fat in places that it shouldn't be, then that's going to lead to metabolic problems. But excess fat, just as a mechanical issue, can also be a problem. And so I like to make sure that we don't just get hung up on, well, diabetes and cancer or heart disease. Those are certainly really relevant, but a lot of people might not have those issues, might not have abnormal lipids, but they've got back pain, they've got knee pain, they can't get off the ground without assistance. They need a knee replacement because of excess weight in the lower extremities, for example. So metabolically, they might be quote unquote healthy, but they've got mechanical issues like sleep apnea. And when you think about the initial insult, one of the things that we found in recent years is that there is chronic inflammation that happens at the level of the hypothalamus, where a lot of the central control for energy regulation occurs. And this is going to create this insult that leads to decreased sensitivity to leptin. Leptin is a signal that tells you when you're satisfied, when you're full, when you can stop eating. And so if you decrease that sensitivity to leptin, that means that you tend to overconsume, right? You're going to increase your energy intake despite not needing to do that. And that comes as a result of essentially having a faulty thermostat, if you will. Now, energy balance is a concept that, you know, sounds mathematically very easy, but it in fact is dynamic. It's a dynamic system where your body stores calories in the form of carbohydrate like glycogen, protein like muscle, and then fat as in adipose tissue and fat cells. And on a daily basis, that system is actually fairly well regulated. And we use fat as our buffer, right? And fat allows us to flex, if you will. When you have more calories around, you put those extra calories in the fat and store that for when you don't have as many calories around, and then you can extract that energy from the fat stores. But your protein stores, your carbohydrate stores, they stay relatively fixed. Yeah, you can do certain things to lose protein or modify your carbohydrate intake, and you'll see your glycogen stores go down. But in most instances, most people, that's not contributing a lot to the 24-hour sort of flux of energy and response to energy changes. But this system changes on a day in, day out, minute by minute basis. And the reason that's important is because I think we have to understand that basic concept of how we store energy and how we release energy stores in the face of excess or famine, those types of things. But ultimately, we have to think about, okay, what's the situation when people are gaining weight? And what are the determinants of weight gain? Because I would argue that any weight gain in adulthood is essentially abnormal. Think about it like this: who's trying to gain weight as an adult? You have to be either pregnant or a sumo wrestler in order to be actively gaining weight as an adult intentionally. Intentional weight gain. Most of my patients would say, I didn't come into this process or think about when I sat down that I wanted to gain weight. I started eating because of some other trigger. And in that process, I gained weight. And it was difficult for me as a patient to figure out how to stop that process. And so one of the things that's important to understand in terms of how people gain weight is that we don't all respond to a stimulus in terms of energy exposure or restriction in the same way. There are two different metabolic types that have been described. One is the metabolically thrifty. So in the setting of energy restriction, so if I say, all right, we're going to cut everybody's calories by 50%. Some people are going to be metabolically thrifty. That means they have a low resting metabolism, low resting energy expenditure. They don't use fat as often or as much. So as I talked about in that dynamic system, they're less likely to access those fat stores when they're calorie restricted. And they have a reduced sympathetic activity. So their engine, if you will, doesn't idle high, right? Their motor sort of is on a low level of energy utilization. It's like they're conserving energy in that state of energy restriction, compared to somebody who might be metabolically spendthrift, which is the opposite of that. So they don't have this low resting energy expenditure. And in the setting of energy restriction, they are metabolically flexible. So they can get to those fat stores easily, and they maintain that sympathetic activity. So their engine sort of idles a little bit higher. And so they're consistently burning calories, generating heat, even in the setting of energy restriction. And so there's some, pluses and minuses to that, right? Metabolically thrifty person is the last person to die in the famine, whereas the metabolically spendthrift person is going to be the first person who wastes away, all right? But in our environment, that's not necessarily a good thing. These data just sort of show you graphically what that leads to. So in the setting of fasting, which you see in the white section here on this bar in top left, the thrifty individual is going to have a much greater decrease in their energy expenditure compared to when they're overfed, right? Or compared to someone who's spendthrift, they have a decrease in their energy expenditure in the fasting state, but it's not nearly the same level as a thrifty individual. And when you overfeed someone who's thrifty, their increase in energy expenditure, so them burning off that extra energy, that response is blunted compared to someone who is a spendthrift. They get rid of those extra calories. And as a result, what you see in terms of body weight is that when you try to restrict calories for the thrifty person, they lose less weight compared to the spendthrift. And when you overfeed the thrifty person, they gain more weight compared to the spendthrift. So same conditions, but people are metabolically going to be moving in different directions based on their phenotype. The other thing that's challenging about obesity is that your brain doesn't understand when you try to restrict calories and lower your weight why you're doing that. That's not a natural phenomenon. You can't point to an animal in the wild that is intentionally losing weight. We're the only species that purposely restricts calories. A bear will do that, but that's because a bear is hibernating, and it gains weight during the spring and summer to hibernate over the winter, right? So your brain senses a loss of mass when you start to restrict calories, and that shifts into play a series of hormonal changes that favor increasing food intake and decreasing energy expenditure. And I would say, if you want to do some really interesting reading, go back to the Ansel Keys Minnesota starvation studies during World War II, where he took volunteers and severely restricted their food intake and did that over a prolonged period of time because they were trying to understand what was going to happen to Jews as they came out of the concentration camps and understand what's the process for refeeding. And you could, the physiology and the psychology of what happens as people are restricting their intake over a long period of time. What we experience as cravings and preoccupation with food is all being driven by all these hormonal changes. And so when you start losing weight on an intentional basis, it's metabolically a good thing, but your brain doesn't know that you're doing that on purpose. And so it totally sabotages the process and makes it easy for you to regain weight because of all of these processes that are happening. So now that we've had a chance to just kind of level set on obesity as a disease and all of these things that are going into place, now I want to really sort of shift into this health equity frame and talk about if obesity is a disease, it affects so many people, and we know the physiology, we're learning a lot about these hormonal changes and the imbalance in energy regulation. Why is treatment so limited, and what do we need to do to improve that? And I'm going to try to make an argument that we can use health equity as a frame, but we got to really understand this issue around why we're in this place in the first, and why we're here in the first place. So very quickly, some prevalence data about obesity. You know this, you've seen this, about 40% or so of individuals, 42% of people have obesity. And you see some differences by race, ethnicity. Black women tend to have the highest rates of obesity compared to other race sex groups. Men tend to be in the 40s percentile, 40% for obesity compared to women. we see differences in terms of prevalence of obesity by race for youth. And again, people of color tend to have higher rates of obesity among youth. And this data set is age 2 to 19 years. But you can see, again, there are disparities, but the prevalence is high. And if I showed you data going back over time, you would see that prevalence has been increasing over time. So I'm going to try to make the case now that I think there are 3 components to sort of get us that really sort of have driven us to this point in terms of why we are not treating obesity the way I believe that we should be. And that's going to then lead us to some discussion about, okay, well, what should we be thinking about and how can we deal with that? So we're going to first talk about obesity bias, and then talk about this idea of monetizing wellness, and then finish up with structural inequity. So obesity bias, is simply put, one very basic way of thinking about this is if you don't understand the concept of obesity as a disease, then you tend to focus on the personal responsibility, lack of self-control, and you think of obesity as basically a consequence of a series of poor decisions that someone has made over and over and over again that leads to the sort of excess weight gain that you see. And if someone was to just simply improve one's lifestyle, then all these problems would go away. And so that becomes the mantra, the basis of the mantra of, well, people should just eat less and move more. And fundamentally, we know that that doesn't work. And based on what I just showed you, you should start to understand why that in and of itself is only going to be a limited impact for some people. Some people will totally respond to that, but a lot of people won't. And I'm going to try to make the case as to, well, what's going on here in terms of this bias. Now, if we were to apply the same bias for obesity to, let's say, the opioid epidemic, if we were to say, okay, this is totally about personal responsibility, these folks just need to do better, be stronger, then the best way to solve the opioid epidemic, if we were to apply the same logic, in my mind, would be to say, well, people need to avoid injuries that lead to chronic pain, because if you don't have chronic pain, then you won't need opioids. Or avoid any dental procedures. So make sure that you just don't go to the dentist, or you do everything you can to avoid a dental procedure, or don't develop something like cancer where you might have pain that's really severe and need an opioid to deal with that. And by the way, we got plenty of other things that you can do. So you don't need opioids for treatment. Just use Tylenol or Advil or meditation, right? Use something like that to deal with the most severe pain. Well, in that case, this puts the onus on the person to say it's your fault for having an addiction, and the fact that you were exposed to this condition and you had a predisposition to it, we don't really care about that. But if you think about the opioid epidemic, it is a combination of people being predisposed to possible addiction and optimal conditions to actually then lead to the actual addiction being manifest. So the opioid epidemic wasn't just, oh, all of a sudden we've got lots of people who are craving opioids or just have a lack of willpower. There were a lot of conditions that were set that then really sort of caused the epidemic to be manifest the way it was. That included things like an easy supply of opioids, large amounts of opioids being produced, increased prescribing because we were telling doctors that patients shouldn't be in pain and that pain can be totally avoidable. We had things like pain is the 5th vital sign. And so every time we asked people about being in pain, we trained them to say, if you had any pain, then we should treat that. And so all of those things come together to create what we now see as an epidemic. And so for obesity, being the complex disease that it is, this slide is here as an illustration of showing you all of these, little boxes and arrows represent one factor that may impact energy balance in one way or another, directly or indirectly. And so you can see the level of complexity here in all of these systems that are going to have an influence on energy balance. Do you think that one person can cognitively, voluntarily control all of these factors to maintain energy balance of their own free will going, on a day in, day out basis? It's nearly impossible to think that that's reasonable. So the way I like to really think about this is that we all live in the obesogenic environment, right? And in that environment, we're all going to have factors that may or may not influence us or have an impact on us. And that could range from things like having access to high energy dense food, or low requirements for physical activity, or an altered sleep cycle. Maybe you work the third shift. Maybe you were put on prednisone, which is a weight promoting drug, or you take a lot of Benadryl, which can increase your potential for weight gain. Maybe you had a traumatic childhood experience. So we know adverse childhood experiences has a significant impact on adult body weight. Or maybe you live in a low resource neighborhood. Any of these things may be impacting you as a part of the obesogenic environment. And some people are exposed to none of these. Some people are exposed to a few of them. I've got patients who are exposed to all of these issues, and they're dealing with all of these. And their level of exposure may vary. It could be high at one time or low at some time, maybe periodic or sustained. And how you respond to that environment is, again, not entirely of your own volition. Some of that may be, but some of that is going to be dependent on any number of other things. And that is going to ultimately contribute to your ability to have energy balance and regulation of energy balance that's effective. So I like to think of our, what we see as obesity epidemic and obesity itself as a response to the obesogenic environment. And that response is going to be highly variable. And that means that we're not blaming the individual, but with obesity bias, what ends up happening is we say, this is your fault. And if you, don't make better choices, then you're the one that's causing your weight gain. Meanwhile, we're just lucky, right? Those of us who don't have obesity are just lucky, or we've got a different exposure to that environment. So we're not as exposed, or we don't have that same intensity of exposure. We don't have to work a third shift job. We live in a nice neighborhood that's safe and easily walkable and has grocery stores and the like. And so we just see that as, well, we just made good choices in life. Meanwhile, none of that was, again, related to, our own, control, all just in our own control. So that's the first part of this, where I think when we blame the individual for obesity through obesity bias by saying it's ultimately your fault and therefore you need to fix it. So that leads to the next component, which is monetizing wellness. And, for most of our existence, food scarcity has really been the challenge for us. And in most instances, when you think about the development of humans, if you were poor, you had limited food and you had to work really hard to get it. And, in most developing societies, if you have food, then that is a sign of wealth, and you often are heavier. Your body size is higher, and that's seen as a sort of sign of success. So, that's the way it has always been historically. And again, still in a lot of emerging economies and societies, that's the way it's currently viewed. But the inverse is true in a lot of high income countries. So you look at North America, you look at United Arab Emirates, or you look at England, the EU, those places, and you will often see that in high income countries, there's a high prevalence of obesity, right? Higher prevalence of obesity in high income countries compared to lower income countries. But that prevalence of obesity is really being borne by individuals who are a lower educational attainment or lower income. So lower SES individuals, and I'm just showing you a graphic for individuals based on education, men and women broken out separately, but you can see the percentage difference between higher education and lower educational attainment is fairly significant. So this is where the brunt of the disease is being born. And a lot of that, I think, is related to this notion that we've basically taken health and wellness and turned it into a commodity. We've turned it into business that you can buy, and it becomes a status symbol, like a Peloton bike, right? Who would think that, riding on a stationary bike would be something that would be, super expensive, and a form of, sort of exercise that, you're going to have to pay a lot of money just to do. But that becomes something that people sort of think of as like, okay, well, I am being super healthy. And in order for me to be healthy, I've got to think about, getting into that type of purchase. Or maybe something even simpler, like simpler ideas that I think a lot of our patients internalize that, if we start to think about them, don't really make sense. But things like, we have a real bias towards fresh produce. When fresh produce is actually more expensive, it has a shorter shelf life, more waste potential, and can be totally substituted for frozen or canned with similar nutritional value. Or we do things like we put emphasis on expensive protein sources like skinless poultry or low-fat versions of certain meats. And again, not always necessary for every person to say like you need skinless chicken breast, right? You could get a whole chicken and actually do just fine. Labels that suggest healthiness that are priced at a premium, like organic or non-GMO or free range, right? These are things that patients will look at and think, well, I can't really afford to buy this. It's the idea of buying blueberries in the, dead of winter, right? I mean, you don't need to buy blueberries in the dead of winter, fresh blueberries, because they're really expensive. Those types of things are the things that I think we have as a society sort of started to place more value on. And that makes, for a lot of people, the idea of being healthy feel like it's too expensive. Here's an example of a study that I think is really interesting. Consumers were asked to choose the healthier of two similar chicken wraps, right? And in condition one, you had a roasted chicken wrap versus a balsamic chicken wrap, and they were priced differently, $2 difference, $8.95 versus $6.95. Condition two, you switch the prices around, same wraps, but just switch the prices around. And people were asked to say, give me your opinion of which one you think is healthier. And do you know what happened? Well, in condition one, they chose the roasted chicken. And in condition two, they chose the chicken balsamic wrap. The only difference, or the only similarity between those two conditions, is that they looked at the price point for each one of those items, and they intuited that the healthier item was the item that was more expensive. So we've, over time, been conditioned to link more expensive item or product or food or fitness routine with being better for you, healthier. And that has really significant implications, I think, for what people are willing to do and how they think about health as being within their budget. So once we get to that point, we've already said it's your fault, so you got to fix it. Now it's going to cost you to fix it. And we're going to pass judgment if you can't, because, if you're a successful, disciplined person, then you'd be able to do this, right? So now we're just sort of piling on more blame, and we're also creating this situation where we're making it really difficult for someone to feel like they can take control of this issue and deal with it in a way that's really, going to help them feel better, change their trajectory in terms of health, and they're going to feel less isolated. So let's move now into this concept of structural inequity. What does that mean, and how do we link that into this notion of, we're creating this bias, we're monetizing wellness, and now we've got structural inequity that is all driving this low engagement on treatment. So I like to use this analogy to try to explain what structural inequity really is all about, because sometimes I think it sounds kind of complex, and it sounds really sort of difficult to grasp and understand, but I think this analogy helps to bring this across. So this is John Snow. John Snow was a physician, an epidemiologist, actually, the father of epidemiology, if you will. And in the 1800s, there was a outbreak of cholera in England, in London. And at the time that outbreak occurred, cholera is a gastrointestinal disease, as you know. A lot of people thought that cholera was actually transmitted through the air, and they thought there were bad, quote unquote, vapors that were going around and infecting people. And so this is why you had this clustering of cholera cases. And John Snow said, I'm not so sure that's the issue. And he made this now famous map, and he actually went through Soho section of London and said, let me figure out where these water pumps are, because I think this is a waterborne illness. And what he did was he talked to all these people, and he said, where do you get your water from? And he started to realize, like, everybody is getting their water from this Broad Street pump. And everybody who's using this Broad Street pump for their water is getting sick. And he started making all of these observations, and eventually he convinced the government to shut off the Broad Street pump. That eliminated that source of water, and people actually stopped getting sick. They got better. And he also sort of figured out, like, hey, there are people within this area that aren't using this water source. Like, there was a bar that used their own water source for making spirits, and they weren't getting sick. And so he put all of that together, and he said, look, this is the problem, and here's how we fix it. And ultimately they were able to fix it. Now, that was science, and that was, using observation to really sort of draw, good conclusions, and then coming up with a plan to fix it. Let's imagine there's an alternate universe where John Snow looks at the evidence and says, you know what, you're right. It's not the water, it is the air. And what we need to do as a result, if the government sort of agrees with that, because that was their prevailing theory, if he goes along with that, and then they say, okay, let's just put a red line around that neighborhood so that those people can't get out of that zone. They have to stay there for everything. You can't leave. You can't go to school outside of that zone. You can't get healthcare outside of that zone, because we don't want those people spreading that bad air over into our other zones. So now they've made an erroneous sort of conclusion about what is happening in terms of how cholera is transmitted, but they've created this red zone. And what do you think is going to happen in terms of the number of cases of cholera? Well, it's probably going to go up in that zone, because those folks have no recourse to get outside of that area. And the problem that was causing the cholera in the first place is still there. It's not been changed, right? And so what's going to end up happening is that it's just going to reinforce the idea that, well, we must have been right, because we kept the cholera from spreading. And those people in that zone, if they had behaved differently, maybe they wouldn't get cholera. we've restricted their access to anything. And so as a result of that, they're likely going to get cholera, but it's not changing the biology of cholera, right? Cholera is still coming from that water pump. And so you've now just reinforced discriminatory behavior, but based on bad science. That's how structural inequity works. When you limit resources, you limit access, you limit opportunity by making a certain policy or making a certain decision like that, it then has an impact, whether it's overt or covert, whether it's direct or indirect, it's going to have an impact on those individuals that it's designed to limit. And when you look at the outcomes and you see, oh, well, see, look, we told you this group of people, they couldn't be, they're not smart, they can't be educated, they're disease ridden, and you limit resources that then fulfill that prophecy, that has legacy effects that goes on well after any of those things are, attempted to be changed. And when you have legacy effects that keep people in power, maintain status quo, because status quo is always hard to change, then that's also going to have a generational transfer effect as well. And so that's how structural inequity operates. It reinforces a system that just rationalizes your ability to discriminate or limit resource distribution because you have already made the decision that, well, this is how this is going to work. And that decision just continues to make you feel justified in what you already preconceived. So if we go back and think, well, okay, well, how does structural inequity fit into this process? Think about this obesogenic environment consideration that we talked about before, this model. And you think about, well, how might someone be exposed to these different components within the obesogenic environment in a way that's, variable by individual? Well, if you live in a certain neighborhood and zoning laws limit fast food outlets in one area, but allow them in other areas, then, in our society, the fast food outlets are going to go to the place where they're allowed to go. And that may be the predominant source of food for some people in their neighborhood because that's what's there, that's predominant. Or if you live in a state that doesn't, have an expanded, hasn't expanded Medicaid, or you don't have insurance, then use of lower cost medications due to lack of coverage or the type of insurance coverage you have may mean that you don't get better medications, you get the older generation medications that are going to be more weight promoting. Or our low resource neighborhoods may be, part of a policy decision or a consequence of policy decisions that are really about the tax base. And so if you have a neighborhood that's got a working class individuals or people are moving away and you have a limited tax base, then there's not going to be investment in that neighborhood. And that's just going to reinforce the idea, well, those people obviously don't want to have nice things because they're not investing in their own community. But the way the policy is set up, they're not going to have the resources to do so. So these types of structural inequities lead to an increased exposure to the obesogenic environment that, again, is not based on individual choice. And so it reinforces this notion that if you already believe that obesity is the fault of the individual and that they need to fix it, then when you look at the distribution of obesity in poor communities or people of color or people with lower education, then it just reinforces this already faulty thinking that says, well, you haven't done anything to change your situation, we were right. And so these things work together. You could draw an arrow across all these to see how it's just continually reinforcing, and you see disparities continue to grow. The other thing that's really interesting about using a health equity framework is that you start to understand, well, these things people aren't just dealing with obesity as, the only thing that they have to deal with in terms of bias or challenges. There's an intersection across different things. We talked about low income or low education, right? People in lower income, lower education settings or backgrounds have to deal with any number of other challenges and biases. What about if you come from a ethnic minority group, or you live in a rural geography or a low resource geography? Once you start putting all of these things together, you could imagine Black woman who, just graduated from high school only, working a minimum wage job, trying to make ends meet in a rural, community, dealing with obesity. All of these different issues are going to be compounded in terms of the bias and the challenges that that person's gonna face. So if we put all of this together and say, okay, well, how does all of that impact treatment? What's the line from this structural inequity and bias and monetizing wealth and wellness? How does that then ultimately impact our ability to deliver treatment or engage patients in treatment? I'm going to give you just several examples that I think are highly relevant, but just based on the work that we try to do. So first of all, let's think about insurance coverage decisions. Who decides what medicines get covered? And if you think about, if you work for an employer, which, most of our healthcare coverage in the U.S. is based on employer decisions. If that person making decisions about treatment coverage for the health plan believes that obesity is just a lifestyle issue and people should take more responsibility for themselves, then they might say there's no need for us to cover weight loss medication. Why would I ask someone who doesn't have obesity to pay for medication for someone who does? We don't ask that question about diabetes or cancer drugs, but we ask that about obesity drugs, for example, or the share of cost passed on to employees. So people may have to pay more for their insurance if they are actually planning to get bariatric surgery, for example, or they may have to pay a higher cost for a weight management program in terms of a copay compared to any other type of treatment. We don't ask a person, who needs a heart catheterization because they have had a 20-year pack history, 20-pack-year history of smoking to say, we don't say, well, you're actually gonna have to pay a little bit more for this heart catheterization or this bypass surgery because of your smoking history. But we pass that cost on to people with obesity. We also have very different expectations of how treatment should work, again, based on this bias. So we think, well, if someone is taking the drug, for example, or they've had surgical treatment for obesity, that, that should fix the issue, quote unquote. And once they stop the treatment, the drug, then they should be fine. But again, obesity is a chronic disease. And if you stop treatment, then the disease will lapse. So we know that discontinuing treatment increases your risk of weight regain. How does this impact treatment? Other examples, medical education, very little medical education going on about obesity treatment. Again, a disease that affects 40% of adults, 20% of kids, very little time spent teaching people in medical schools about how to treat it and how to engage patients in a way that doesn't promote bias. As a result of that, you see patients who are very apprehensive to discuss obesity or even sometimes their health at all with a practitioner because they understand the answer is always going to come back. Well, if you just lost a little bit of weight, or just do the same thing that I've told you to do 10 times before. And clearly that's not working, but we're continuing to provide that message. Or what ends up happening is we see people waste resources, engage in treatments that have very limited benefit or no potential for benefit, or might even be harmful. And the thing that is most concerning to me in this day and age where we have new therapies coming to market that are highly effective, but also very expensive, is that I think we're going to see potential widening of disparities where individuals who are most likely to suffer from obesity because of lower income, education, race, ethnicity, rural geographies, et cetera, are not able to get to these drugs, not able to get treatment. Whereas those of us who have better access and better insurance and, you know, more educated, more health literacy will be asking for these drugs, and they're going to get it. And you're going to see a widening of disparities in terms of those who can get treatment, those who can't. So let me finish up by talking about what can we do, what might be possible for us to really sort of engage on. And this is where I think we just need to say, okay, what are we talking about in terms of the idea of trying to get to health equity? It basically means that everyone has a fair and just opportunity to be as healthy as possible. It doesn't mean that everyone will be as healthy as they can be, but it means that we understand that there are obstacles to health, like poverty and discrimination, and the consequences of those decisions and those structural inequities that lead to an inability of people to be as healthy as they possibly can. And so we have to address those things. We have to remove those obstacles in order to give everybody that opportunity to be as healthy as possible. And so in order to do that, it means that we actually have to acknowledge that there are indeed differences in the ability to achieve the outcome and then address that, right? So in the picture on the left, you see what equality looks like. And this is where I think we have been and have focused, you know, to a large extent is, well, let's just treat everybody the same. Equality means we're going to give everybody a box. And if you can't see over the fence, then too bad. Maybe we'll teach you how to jump. But, you know, it's going to be your job to figure out how to use what we give you in order to be successful, versus equity on the right-hand side says, well, we realize there are differences at the beginning here, and we actually need to adjust for that. And so the person on the far right actually needs 2 boxes in order to achieve the same outcome as the person on the left, who actually doesn't need a box at all. So for obesity, what does that mean? I think it means that we start with trying to work on eliminating bias and really teaching our colleagues and our family and our friends about this idea of obesity as a disease and the impact of the obesogenic environment. At a societal level, at a systems level, we really need to understand how that environment is having a negative impact and work together collaboratively to really try to reduce the impact of the obesogenic environment, or at least see how can we reduce the exposure to said environment, especially in those who are most vulnerable. That means equitable access to health promoting resources, so making healthy food available, making physical activity easily accessible, all of these things that we would like to see as a part of a healthy lifestyle that helps to promote, you know, sustainable energy balance, but also helps in prevention. And then we've got to, I think, increase emphasis in medical education. We've got to advocate for treatment across all age groups. And we've got to really embrace this idea of a chronic disease and use chronic disease model. So our challenge, my challenge to you, is to consider in any work that you do, what's the impact on health equity? And I think anyone who's doing anything from basic science to community-based participatory research and all along that translational spectrum should have this as a consideration. What is the health equity impact of your work? Maybe it's really, you know, direct and focused. Maybe it's indirect. Maybe you don't know it just yet, but I would encourage you to think through that and collaborate with people who might be able to help you understand what is the impact of your health, of your work on health equity. I think you want to reduce your own bias. Think about, how do you talk about obesity? Do you talk about it as a disease, or do you talk about it as a character trait of the individual? Do you say this is an obese person, or do you say this is a person with obesity? Because if you say this is an obese person, then you're now characterizing that person as the disease, where I don't think we want to do that, right? We want to talk about this as a disease that a person has, not as a disease that the person is, right? We don't say this is a person who is cancerous. We say this is a person who has cancer. And so little things like that help you start to reframe how you even conceive of this disease, and that opens your eyes to all the different ways that our society is just, attuned to not treat people with obesity with the same respect and the same level of equity. And then I think we need to continue to educate ourselves. I mean, this is a really fascinating area in terms of the science of obesity and where we are with this new developments of treatment. But I believe that there's always more we can learn. And as we learn more, then that's going to stimulate us to help educate others who will see us as leaders in the space. So I appreciate everybody's time and attention and hanging in there on a what looks like outside my window now, a stormy, at least rainy evening. And hopefully everybody is safe at home and doesn't have any other severe weather coming their way. So thank you all very much for your time and attention.
Thank you so much, Jamie. That was an amazing talk. You really covered a lot of ground. We have a little bit of time for a Q&A. I see lots and lots of clapping emojis here. If you'd like to answer a question, I think the group is not tiny, but maybe small enough to have you raise your hand. I'll ask a quick question. Do you think, so you've given us lots of information and lots of insight into what it's like to all the issues that people with obesity deal with, and the potential biases, both personal and systematic. What kinds of tools can we give clinicians or the public to better address obesity?
Yeah, so I think this is where we need lots of bright people like the folks here, networks of people working together to really sort of help create these types of tools. I know that Leah Wiggum and her team are working on tools where they're talking to clinicians, primary care providers about how to initiate that conversation with their patients in a way that's respectful and engaging. We need tools that will help people advocate, for themselves, right? So I'm a big proponent of the patient improving their health literacy to be able to use the right words and to engage the providers, the practitioners in the conversation. I also think that we need in our given spaces to be able to talk to politicians and business people about the impact of obesity in our communities and really give them the same type of education that we talked about this evening, because I think the more we change minds and have those conversations, I think there's going to be a gradual shift, but we have to have those conversations. The way we had conversations about mental health in the 90s, right, when people were, hesitant to use SSRIs for treatment of depression or anxiety. And we were still learning about the neurochemicals that, were needed to be supplemented as people were dealing with these mental health issues. It took a lot of conversations, but we changed the culture around that. And I think that's part of what I believe we should be doing in terms of trying to, like you said, these types of tools that we can deploy to really sort of help move the needle.
Yeah, I think you're right. It's a kind of a global, at every level sort of intervention, but also giving people education and tools like you talked about. Welcome questions from the audience. A few questions before we sign off. Just raise your hand. You can add a question in the chat. A lot of nice comments in the chat, Jamie.
Thank you, everyone. I see a hand raised, Kennedy Hawkins. Go ahead.
Yes, hi. Thank you for this lecture and doing it on Zoom in short notice. I was just wondering how fast you could imagine a change towards more public education about topics like this and obesity awareness and equity for this kind of stuff.
Yeah, so I think this is a really important topic, and I'm actually going to maybe put on my Obesity Society hat here in response to this. I would like to maybe put out a call for anyone interested in terms of thinking about, you know, how do we create essentially a public service awareness campaign that really sort of gets at some of these issues around obesity as a disease and the bias and the stigma. Create a campaign that really goes to educate people in a way that is positive and supportive, but really gets at the points that we need to help people get access to treatment, that we need to do things at a level that help to prevent obesity and excess weight gain and make our environment safer for people. I think something like that can be done. And there are plenty of models that I've seen, you know, the American Diabetes Association use, American Cancer Society has used that. You think about the tobacco cessation or prevention campaigns that have been done, right? We have the know-how to do that, but I think we just need the political will, and we need people engaged to be able to do that. And that means, you know, a lot of our professional societies, a lot of our institutions need to be coming together to really sort of think about how do we resource it and get something like that done. But I think that something like that is absolutely doable and would have an impact, right? That can be measurable.
All right. Thank you so much.
Sure thing.
Any additional questions from the audience? So Jamie, I guess as you noticed, it is raining pretty hard. I don't know about where you are, but where I am, it's pretty hard. So I guess we made the right decision. Thank you for being a wonderful speaker, bringing us such important messages, for switching on a dime to a different format and doing a great job. And have a nice evening, and all of you guys stay safe and dry.
All right. Thank you all. I appreciate
Bye,
it.
everyone.
Bye-bye.